Good morning. This is the beginning of our SWOG fall meeting of the Palliative End-of-Life Care Committee. We've been given the go-ahead by our IMS operator, Brooke, so we are live and we're populating the people who are the participants, and we've got our panelists on board. My name is Mark O'Rourke, and I'm one of the co-chairs of the Palliative End-of-Life Care Committee, and I'm joined by Marie Bakaitis, the other co-chair, and Robert Kraus, the first co-chair. So we are looking forward to a wonderful program this morning to update the audience on what the committee's been doing and to catch up with people along with a guest speaker. So a good program. I think we're pretty well populated, and we can go ahead, Brooke, and start the meeting then. And if I could have the first slide. And this is our run sheet of what the meeting is going to look like. And we can go on to the next slide. And this is our committee. I want to shout out to Dr. Frank Meskins, who is our senior advisor, who has really brought this committee to life and has been our inspiration. And I hope he's in the audience. I haven't had checked this morning. And then I also want to encourage people to leave your camera on. So we're palliative care people. We're into our inner human connectedness. And so I encourage you to leave the camera on so we can feel like we're in person, even though we're not. But we have a tremendous team that includes patient advocates led by Valerie Frazier, but including Lee Jones and Carol Siegel. And we want to give them just a time to update our busy patient advocacy efforts. And I will, at this point, turn it over to Valerie.
Thanks, Mark. We've been active on a lot of the trials and protocols that are up and coming. But I wanted to just give an overview of the advocates on our committee today, because a lot of people are not maybe aware of who we are and what our backgrounds are.
Next slide.
So I'm Valerie. I'm the lead Palliative End-of-Life Committee advocate, and it's a pleasure to serve on this committee as the advocate and be able to work with so many dedicated investigators developing projects and trials that are important and impactful for patients. This committee's research is so pivotal in helping to advance quality supportive care for cancer patients during the most critical times of their illness, as well as their caregivers. As we all struggle to continue our lives during COVID, these patients and their families must not only face the difficult treatment and care decisions that come with critical illness, but must also now absorb the additional uncertainty of navigating this deadly virus as well. And this makes the work that we do on this committee even more compelling. You'll see on the following slide, there's a brief overview of the committee advocates who each bring their extensive patient and advocacy expertise and experience to the research development and planning table. My own advocacy work began 14 and a half years ago when I was diagnosed with a deadly form of cancer, and after losing both my parents and several other relatives to cancer. My passion has been to make a difference for patients through research and research advocacy, which has led to my work with SWOG and many other cancer organizations to support and lead research that's important to patients nationally and internationally. Lee Jones is the lead advocate for the Survivorship Committee, as well as being very active in this committee. He is a survivor of stage 4 colon cancer, and he also serves on the NCI Central IRB, and is a research advocate with a number of organizations and on many levels in his state of Virginia. Carol Siegel is the lead advocate for the GI committee, as well as being active on this committee. Carol's husband lost his life to pancreatic cancer, which led her to become a research advocate and being involved in her state of Massachusetts and nationally. She is also an advocate advisor for the National Pancreatic Foundation and also works with ASCO and ACS. We are all thrilled to be a part of the impactful work taking place on our committee this year, and we look forward to our continued growth and promise of new emerging concepts and trials yet to be. So thank you.
Very good, Valerie. Thank you. I appreciate your summarizing everything, and we really have had an extraordinary involvement, including at our preparatory meetings with the advocates. So we appreciate your efforts and more good things to come. I want to, Dr. Meskins is on the call, but we've learned that I guess that you can't see everybody else's pictures, so that's a technical project we're going to try to figure out eventually.
Actually, Mark, I was working with Brooke, and he's going to make everyone panelists so that they can share their cameras.
Okay. Yeah, so that's great. So we would, and again, we work on this personal connection, and it's extremely important to us. The next part of
reminder just would be is to keep on mute. We're excited to see everybody, but just make sure you're on mute unless you're actually talking.
Well said. And if we start hearing dogs barking or children crying in the background, we'll understand. So, the next is our committee member well-being check-in, and Marie has led the effort in this. And go to the next slide, please. And I'll let her take the floor at this point.
Thanks, Mark. And thanks to the folks who have volunteered this or been voluntold, one or the other, I'm not sure. Welcome everybody to the meeting, and I wish we were actually in Chicago, which is my background, for us to get together. But in an effort to just stay in touch, and because there's so many of us and we're not at the meeting, that we can just have some informal time to chat and catch up, I've asked 4 of our members to say a little bit about how things are going in this time of continued ongoing pandemic and the syndemic of the COVID-19 and our social injustice issues that we have not completely solved yet. So anyway, Mark, you're our first person to share today, and just a couple minutes on how things are going with you and your patients and your practice, and then any strategies that you've been using to keep your resilience and hope alive.
Well, thank you, Marie. And I've listened to others have their reflections, and in my gender stereotype, I'm not used to sharing my own thoughts, but I'll try. I'm impressed that the pandemic is wearing me down like everybody else. It's just so tiresome, and I have been increasingly irritable. And over the years in my career, I've had to work on temper and irritability. And I'm noticing even patients are sometimes chewing out the doctors and getting upset at things that are real, but even more bothersome. And in my own self, I mean, I get my mental health follow-up and am treated for depression, which translates to irritability. But I've noticed this in the last month or so, a couple of times when I really got mad about things, and my anger surprised me, and I thought I'd been doing pretty well in recent years. So I'm feeling it, and I'm sure others are. My strategy is to spend time with people who don't care that I'm a doctor. That is, people that I have a relationship with outside of medicine and outside of career, that it is completely not professional. And I enjoy the fellowship of a bunch of old guys like myself. And we go out to breakfast, and we call ourselves Romeos, retired old men eating out. And that
I love
finishes,
that.
that finishes me.
Oh, Thanks so much, Mark, for your sharing and your candidness. Virginia, would you please go next?
Sure. Thank you so much. It's so great to see everyone virtually today. When the pandemic started, as many of all of you have experienced, our research team had to pivot very quickly back to, doing work at home. So we've really try to focus on three things: gratitude, self-care, gratitude that, grateful that we have access to life-saving vaccinations, while there are still many people on this planet that don't have access to that. And then grateful that we are still able to continue with our work and our research despite the challenges, and also focusing on the need to take care of ourselves and each other. So really encouraging everyone to take time off if they need to, and as much as they need to, given the stress level. For our patients and caregivers that we are taking care of on our research projects, we wanted to sort of understand what they are going through. So immediately in many of our projects, we had amended our protocol and started asking some open-ended questions with our participants about how COVID changed their well-being and changed their care. And we have also had some interviews done with our oncology teams as well. And so using that data, we are learning in terms of how we as a team can, better take care of our patients and also collaborate with our oncology team.
Thanks, Virginia. I appreciate you sharing your thoughts and insights so much. Catherine, do you mind going next?
Not at all. Sure. So I'm a statistician. I've been working at home. I'm sitting at a desk in my bedroom, which I've been doing now for going on 2 years. At first we were really focused on how lucky we were and we are. My husband's a teacher. He was teaching from the living room. My kids were in high school. They were both in their rooms and we're all together at home and not driving each other crazy as much as I would have thought. Actually, I found this fall to be the hardest time since it's getting dark and rainy here in Seattle. And now my husband's back in school teaching and my daughter's back at school. And so I'm mostly on my own a lot. And, work is fine. And I'm lucky to have a great job and I can do what I need to do from here. But I really miss the camaraderie of the office and of in-person meetings and hanging out with other geeky statisticians like myself. So it's been all right. The things that have been my strategies are, as I say, gratitude, like Virginia says, big time. We haven't been sick. We're all fine. We still have jobs. My faith and my faith community are really important to me. I'm a practicing Christian, and we have lots of stories in our faith about times like these, times of exile, times of wandering in the desert, and not knowing what's going to happen. And I'm finding that pretty comforting right now, and doing online worship and online gatherings with my faith community. And I also got a puppy. So I have a beautiful black lab puppy who keeps me company and keeps me busy. So anyway, that's me.
Catherine, thank you so much for sharing. And I really hadn't thought of it, but the whole theme of exile and isolation, really resonated with me. Yes. And I really hadn't thought about it that way too. And sort of the strategies to deal with that, but it has felt a lot like that. So thanks so much for sharing your thoughts. And last but not least is our member, Christine Ritchie. And Christine, because maybe everybody doesn't know you, would you also just introduce yourself a little bit more?
Oh, sure. Greetings, everybody. I'm Christine Ritchie, and I'm a palliative care physician and geriatrician at Mass General Hospital. And I also co-lead the Palliative Care Research Cooperative that is a very proud partner with SWOG. And so we're just always grateful for our connections through our work together. In terms of reflecting on these important questions, and so appreciate what has already been said, I would just say that I too, like others, have been very much deeply impacted by the suffering that I see all around me. You know, the disparities that seem to just be growing with each passing day, the challenges that are faced by our patients and by the caregivers of those who are caring for our patients. So many fellow colleagues who are struggling because of their own caregiving challenges, either with children or with aging parents, and also trying to sort of maintain a sense of cohesiveness with their work. I mean, they're all around. I think some of the challenges that we're seeing, that's one of my sources of joy right there, Mitchell. But also challenges around civil discourse and how we communicate lovingly with each other without judgment or, you know, shame. Those are all things that I see being eroded, and that makes me very sad. In terms of sort of how I'm navigating the challenges that we're all facing here in the community, a lot of it has been through just letting go of my own attempts or temptations to cling to things that I miss or crave things that I don't have, just trying to let go of all of that. Poetry, meditation, and then most recently and very importantly is just embracing the beauty and abundance of the universe through hiking and nature, and then leaning into the joy that comes through human connection, however it can be found. And grateful for FaceTime and these times together when we can be facing each other, even though we're not together in person. And then for those very special moments when there actually can be connection through presence, through physical presence, whenever that comes. It just seems particularly special these days, given how infrequent it seems to be occurring.
Christine, thank you so much. And I do also want to call to everyone's attention in the chat. Thanks, Banu, for posting about, and others, please feel free to post about what is going on in your neck of the woods as we think about just, you know, how it is to try to maintain some kind of normalcy when nothing is normal. And so thank you so much for sharing in the chat some of those other things. So can we have the next slide, please? It's now my great honor and pleasure to introduce my colleague. I will be very personal and honest about this. Nick and I have worked together for 10 years now. He and I were met up at Dartmouth when he was a doctoral student. And I would say that aside from my partner, my life partner, he's probably the one I've spent the most time with. So when it came time to introduce him for this meeting, 5 minutes ago, I texted him and said, hey, can you send me a formal introduction? Because I'm just so used to knowing who he is. And so for our meeting here, I am going to share a formal introduction of my colleague and friend in crime and research, Dr. Nick Dion Odom. So officially, he's an assistant professor here at the School of Nursing at the University of Alabama at Birmingham. He's the co-director of the Caregiver and Bereavement Support Service, which is an inaugural service that he led and developed here at UAB. And I think we'll tell you a little bit more about how he's working on getting that expanded as an incubator nationally. He is board certified in hospice and palliative advanced practice nursing with 10 years of clinical experience in critical care and 10 years of telehealth palliative care coaching. His research, which he will be telling us about here, focuses on developing clinical trials, testing early telehealth palliative care interventions for underrepresented and resourced family caregivers of persons with advanced cancer. He is also a fellow in the Hospice and Palliative Care Nurses Organization, and he is being funded by the National Cancer Institute, the National Institute of Nursing Research, the Gordon and Betty Moore Foundation, and the Cambia Health Foundation. So if that's not enough for you, just make sure you keep your hands and emails off of trying to recruit him to any of your institutions, because I have the death grip on him and I'm not letting him go from UAB. Welcome, Nick.
Thank you so much, Marie. And you know, probably one of the most powerful things I tell my mentees now is that will make the biggest difference in your career is to have a mentor that sees a vision of you that you don't see in yourself. And so it would be remiss if I didn't say in gratitude how much Marie saw a version of me 10 years ago that I never imagined. And so that's why I'm here speaking in front of all of you today. So what screen can you all see? Do you see presenter view or do you just see the PowerPoint? Just the PowerPoint?
Just the PowerPoint.
Yay. All right. So good morning. I bet many of you listening out there can bear personal testimony to the stories of families you see every single day who serve with us as key partners in the patients with cancer that we care for. And hopefully what I will talk about today will magnify some of those personal stories for you as we think about how do we best support our family members, our family partners of our patients whose world has been turned upside down by cancer. So today I'll have us think about three questions. First, why do family caregivers matter? Second, what is the state of the science in testing and translating caregiving support? And thirdly, what is my current work in the area? And hopefully this will all foster some conversation and discussion about what we might do in SWOG. So the first question to ask is, why do family caregivers matter? And I think for many of us, this is intuitive, but just to put some numbers on our intuitions, every 5 years, the National Alliance for Caregiving conducts a national survey to ascertain at a population level the epidemiology of caregiving. And in 2016, they published a special issue on cancer. What they found was that of the 40 million US adults who care for someone due to a disability or illness, that's 1 out of every 5 of us, about 3 million provide support to a person with cancer. So that's about the size of Houston, Texas. So just imagine right now walking through Houston, a large city, and every single person that you saw was caring for someone with cancer. Now these folks are undertaking tasks that we typically see nurses and social workers perform on a daily basis. You can see quite a few of them here. Many of these things are things that we've often gone to school for, that we were professionally trained. And about 3 out of 4 caregivers are saying that they perform these sorts of tasks. However, about half have said that they have absolutely no preparation for doing any of these things. So just imagine for a moment walking around your hospital and every single nurse, social worker, clinician that you saw had no training. I mean, I think for a lot of us, we would immediately have a panic attack. Not only are they doing a lot of these nursing tasks, they're also undertaking many day-to-day tasks to help this person live a typical day-to-day reasonable quality of life. I won't read through the list here, but you can just see that this is equivalent to a full-time job, particularly when someone has an advanced cancer. One of my particular interests has been in family members' role in decision-making. And here's a paper by Gabriella Hobbs and colleagues of about 5,300 patients with advanced cancer, finding that about 50% shared decisions equally with their family, and another quarter or so, at least some family input on decisions around cancer treatment. And so about 3 out of every 4 cancer patients are saying that they're specifically involving their families in these very key decisions. And some of my own qualitative work has tried to describe in depth what this role looks like as they are seeking information. They're often trying to keep everyone on the same page with what the situation is and what the decisions are. They often are the ones who sit on that front porch and discuss with patients what their understanding is of what their illness is and what their values are. They're often posing a lot of what if scenarios. What if this happens? What if that happens? What are we going to do? They often have to make a lot of collateral decisions. When a person is diagnosed with cancer, it has a domino effect on every single aspect of life. And so they're having to now make decisions about things like work and health insurance, taking care of children. They often are the ones that are identifying the decision point that even needs to be made. Classic example here is when to go to the emergency department to seek emergency treatment. And at the as one is dying, they often also serve as surrogate decision makers. So for all of these roles, one might be thinking, gosh, that's a lot. It's a full-time job and it's stressful. So it's no surprise that cancer caregiving can be a serious threat to one's health. In fact, about half experience anxiety, close to that also experience clinically high levels of depression, about 1 in 4 experience high financial strain, and about 15% experience pretty paralyzing pre-loss grief, which we know tends to predict post-loss complicated grief and bereavement. So what's the state of the science in developing and testing caregiving support? So we have these partners in care, they're delivering a lot of support. They're also psychologically, physically really getting compromised in many ways with this role. So what are we doing to provide support? So over time, the number of trials of interventions that have been tested to support caregivers has been increasing exponentially. Here you can see these are based off of a couple of systematic reviews that are relatively recent, and you can see the number of trials are skyrocketing, which is a good thing. So just to clarify here, 2016, 2020, I just simply hadn't populated all the way up since the last review was 2017. So please don't think of that as a drop off. I just hadn't yet populated that bar of the graph yet. So when we think about, so how effective are these interventions? Here is a table where we're looking at the impact of caregiving interventions on caregiving outcomes. On the left, you will see systematic reviews and meta-analyses that are recent within the past 10 years. Across the top, you will see key outcomes, caregiving outcomes, including quality of life, physical health burden, anxiety, distress, depression, and relationships. If you see NS, that means it was non-significant. If you see a small dash, that means they did not measure it. And if you see an effect size there, those are effect sizes, that means that these findings showed a positive benefits under that dimension. So I think the big takeaway here, when you just kind of generally look across the table, is that, yeah, like our interventions actually do have a positive impact on caregiving outcomes. They seem to have some clinically significant small benefit for these folks across many different domains. So one might then ask, well, how about patients? What is that looking like? Here, similar table, except it's focused on patients. Across the left, you have meta-analyses. Across the top, key outcomes. And this is a really critical, important slide here because it's showing that when we support caregivers, patients benefit. You can see here they benefit not only in their quality of life, but in many other domains. Still working on symptoms there, but a generally good indicator that when we help caregivers, we're also helping our patients, which will come into the conversation when we start talking about how do we justify implementing these programs into real life practice. So why don't we see family caregivers being adopted into practice? The number of intervention trials are growing. They seem to have positive benefit for both caregivers and patients. I imagine many of you, when you're walking around your cancer center, probably don't see a really formal, systematic caregiving programs going on. Maybe some of you do. I would say they're probably not widespread, but so why don't we see more of these? And there's a lot of reasons for that that have been sort of topics of debate recently. And so a number of these challenges include utilization and costs. We just don't have great data on exactly how supporting these caregivers impacts patient healthcare utilization and costs. These interventions are often limited to caregivers at a single time point or single setting. They don't have good generalizability across settings. The needs of families are often varied and complex. They often require more than one program, which can be a lot for a cancer center to take on. Interventions are often not tested in real-world delivery settings within existing payment structures. When many of us receive grants, we have hundreds of thousands of dollars that we can spend on personnel and staffing and program development. And for real-world settings, they simply do not have that. We have to work within the existing payment structures. And on that same note, there's very few reimbursement and payment mechanisms. Most of you, all of you are not reimbursed to provide direct support to family caregivers. There are some exceptions, but not many. Finally, we have scope of practice limitations. These individuals are ultimately not our patients. They do not have MRN numbers. We cannot write CPT codes for them. And so we have to be careful about what exactly we can actually do with these family members. We have a lack of mechanisms to really identify and refer families who could benefit. Seems very simple and straightforward, but we don't have a lot of public health level surveillance mechanisms to identify who in this patient's world is providing them the most support when they go home. And finally, we really lack an available workforce to deliver support services. Many of you, I would guess, if I asked you if you could support families, would say, heck no, like I barely have time to see my own patients. You're basically asking me to double the number of people that I now see and treat. And so the workforce, especially during this COVID era, is already very tax constrained. So how can research cooperative groups help facilitate clinical trials of cancer caregiving interventions? And I wanted to make a brief plug. Dr. Ritchie introduced herself as the co-leading the Palliative Care Research Cooperative Group. Here is the website there. It was established in 2010. It's funded by the U.S. National Institute of Nursing Research to develop palliative care research capacity, most especially multi-site clinical trials in the U.S. and internationally, and to train and mentor clinician scientists at all stages of career who are really committed and focused in the palliative care context. So the Pcrc structure consists of a collaborating set of centers and cores that support investigators and research teams. One of these cores is the Caregiving core, led by Dr. Betty Farrell and co-led by that other guy that you see on this image. And what we do is we provide research consultations to teams developing proposals for the Pcrc network to help them think about how to integrate caregiving research into their studies. So we talk about everything from aims to measures to use, that's a very common one, to how to recruit and retain these populations. I'm spent this morning reviewing a qualitative interviewing protocol for someone funded by Pcrc. And so that's the kind of service that we provide as a core, amongst offering many other resources such as a measurement database. So if you would like and have time, take a picture of the slide, please check out our Pcrc website and our core page, and that'll give you a sense of what we're able to offer other research team services for regarding caregiving research. So finally, I'll talk a little bit about some current work that I'm doing on testing support for family caregivers. I have two large trials going on right now. The first one is called Project Enable Cornerstone. It's an early lay coach-led palliative care intervention for under-resourced African-American and rural dwelling family caregivers of folks with advanced cancer. It's funded by NCI. The purpose is to determine the effectiveness and evaluate costs of a multi-component lay coach-led intervention for under-resourced family caregivers versus usual care. It's a type 1 hybrid implementation effectiveness RCT. It has two arms. And our target enrollment is 294 African-American and rural dwelling family caregivers of patients who've been newly diagnosed within the past 60 days with an advanced cancer. So what does it look like It's initiated again at diagnosis with a long-term follow-up. We follow up with folks 6 months into bereavement. It's targeted African-American and rural dwelling family caregivers who tend to, these two subpopulations tend to have difficulty with accessing palliative care historically. It's lay navigator coach led. That is one of our lead coaches, Shanara Das, pictured there, where we have a mix of phone and in-person interaction. During COVID, we have been almost exclusively telehealth. And so we haven't had much in-person interaction, albeit we're really excited to do some of that in-person stuff soon. There are 6 core coaching sessions that are held over the phone, lasting 20 minutes minimum. If folks want to talk more, we can take up to an hour using a toolkit that we put together that the cover page is pictured there. And really, we offer also a mix of distress screening and problem-solving support as part of the acute support that we offer in addition to psychoeducation. So just to say a little bit about what Shanara and the other lay coaches do, the reason that we've tapped into these folks is because they've proliferated since the passing of the Affordable Care Act. There's just more navigation programs nationally. Cancer centers, they offer one-on-one guidance to patients and families across health system settings, which is great because they're not limited to one single setting. They can follow people across the different care contexts. They're very respected, they're trusted. They look and sound like the people that they're trying to interact with, and have also been shown in studies today to enhance access to health services. And for me, for those, when we talk about a strained workforce, this represents a largely untapped workforce who could really greatly expand the reach of palliative care services and support to these families. So for me, I feel that this is a good potential solution to offering this additional layer of support to these families. The other part I'll highlight here is our 6 coaching sessions and what those look like. In the first session, it's really the lay coach asking about the caregiving story and what it's been like for them. We then talk about coping with stress, getting help, improving their support skills, reminding them to take care of themselves, how to plan for decision-making in the future. We follow up with them monthly, indefinitely, and then close out the relationship with the bereavement call. Here is just a schema of the trial. We collect data every 12 weeks, actually indefinitely, and even go so far out as to 12 and 24 weeks post-death. The second trial that we have is called Cascade. It's a decision support training intervention for family caregivers of folks with newly diagnosed advanced cancer. The purpose here is to test components of a decision support training intervention called Cascade that contributes meaningfully to improvement over 24 weeks. It's a factorial trial design, a relatively newish type of trial design that tests components of an intervention as opposed to a fixed package, where we're targeting 352 family caregivers and their patients with newly diagnosed advanced cancer. It looks very similar to Cornerstone in some ways, but it's more targeted at training decision support skills. It's more broadly targeted at family caregivers in general. It doesn't have a specific subpopulation that it's targeting. It is still lay navigator coach led. It does still include both phone and in-person interaction. And depending on which group you get randomized to, you get anywhere between 1 and 5 coaching sessions using our toolkit. There's 4 main components that we're testing in this trial: coaching on how to be an effective source of decision support, communication skills training, auto decision guide training, and monthly follow-up calls. And for the effective decision support training, it's either 1 versus 3 sessions. For communication skills, it's 1 versus no sessions. Auto decision guide training, it's 1 versus no sessions. And follow-up calls, it's 1 monthly follow-up call versus monthly calls for 24 weeks. Another way to look at this is like this. Because this is a factorial trial and we're testing components, there are 16 conditions. For folks interested in learning a little bit more about factorial trial design, I do have extra slides if there are questions about that. But here's just how you can see how there's an individual is randomized to 16 conditions. And you can't really see in this slide, but the components are split half and half in these different experimental conditions. Again, happy to sort of explain more how a factorial trial works if people have questions. So our current progress with Cornerstone, as of today, actually, we've randomized, or I guess I did an update, we've randomized 64 caregivers and 50 patients. That would be recruitment month 9 of 42. So we're doing pretty good on our pace of recruitment. And then for Cascade, we've just recently published the pilot, and the R01 is currently in startup. We'll begin enrollment hopefully in January of the new year. It takes a village to do all this work, so I do need to extend my gratitude to the co-investigators, collaborators, and research staff that are all involved in these projects. They are actually the one that makes the magic happen every week. And so I do want to extend gratitude for them. And with that, I'll stop and love to take some questions.
Thanks, Nick. And I'll moderate the questions. There are some in the chat. And so I'll just go through those. And also, Dr. O'Rourke, thank you so much for reminding us to, there's many advantages to joining the Pcrc. And there are directions on the webpage for how to become a member, so you could have access to all of the resources and people like Nick, even though he's on our committee, our Palliative Care and End of Life Committee here at SWOG. That's a great way to have resource access to him about caregiver trials. And so Laura Klebs wanted to know your thoughts on how these programs and cancer support can integrate with behavioral, mental health support systems.
That's an excellent question, Laura. Thanks for asking that. The first part of this program of research here is to first demonstrate that this model of support is in fact efficacious and effective. And then the next step would be to develop implementation strategies to get these integrated into real world settings. So before I could say how we should integrate it, I want to first make sure that it works and that it is indeed effective. Some of the components that I've built into this current trial to make it more easy to implement, including the use of lay navigators, so that we're not relying on some professionally licensed clinicians to deliver it, knowing that all of you are strained to the max as one way. And then the others, we have an economic evaluation built into this, including measuring patient healthcare utilization outcomes and how much it actually costs to deliver the intervention. We're hoping with this sort of data that it can be compelling to both health systems and payers to support these kind of programs financially, whether it's through cost aversion or other means. So I'm not sure if that exactly answered your question, but.
Yeah, and you all can, if you can turn your microphones on, you're welcome to. I know we're a little bit behind, but I want to take at least the next 5 minutes, and we'll try to be quick with our other agenda items so that we have till 10:50. Mark and Robert, if that's okay with you.
Fine.
Dawn Hirschman's asked, Nick, can you explain the primary outcome of decisional conflict and how that translates to patient outcomes?
Yeah, great question, Dawn. So that primary outcome is actually reported by patients. So while we're doing this, while Cascade is focused on enhancing the decision support skills of these family caregivers, the primary outcome is actually reported by patients. So what we want to see is that if we can train caregivers to be really effective sources of social support and in particular in making decisions, that actually shows up on the patient end as having an immediate proximal impact on recent decisions that they're facing. And the decisional conflict scale just happens to be one of the most common used in trials. And so that's the reason for it being the primary outcome for that particular trial.
Dawn, did you have any follow-up that you wanted to?
No, I was, sometimes when we do these trials, instruments like that always sometimes get, picked apart. I think it's an important and meaningful outcome. I was just curious in terms of how always the devil's in the detail in terms of which instrument you choose as the primary outcome for these things. And so I was just interested to hear your rationale.
Dawn, I'll agree with you. It is not my favorite instrument. It was sort of a mix of what many other trials have also used. And I'm probably one of the ones that have jumped into the conversation about how relevant decisional conflict is as an outcome. We also are measuring things like anxiety, depression, quality of life, and such. And so those are also outcomes that we're taking a close look at.
So Nick, did you get any pushback from the reviewers of this trial when it was funded as an R01 about your primary outcome?
We did not. We did not. So I was actually kind of surprised about that. I thought that I would have if I was the reviewer.
Yeah, I mean, we've used that instrument for some SWOG trials and gotten a lot of pushback from the steering committee. And I think that's where, you know, some of the differences between the reviewers and the steering committees come in. So it's an interesting point. Thank you.
And Don, just to clarify, this is an optimization trial. So the idea is that we'll identify the best components to put together into the final package, and then we'll conduct what we call confirmatory traditional 2-arm RCT. And for that primary outcome, we would reconsider what would be the best primary outcome. So for this trial, we're just identifying the best package of components.
So Krista Braun-Inglis has asked where the two trials are available. And I would use this as an opportunity, Nick, to speak about the Betty Moore project that you didn't have a chance to mention, because Krista's in Hawaii. And I bet you're looking for people to help with the Betty Moore in Hawaii.
I would go to Hawaii. Sign me up. Yeah, great question, Krista. These two trials are not to the SWOG network. Unfortunately, I wish they were. They both are 2-site studies, both include UAB. Cascade involves Emory, and Cornerstone involves Mitchell Cancer Institute, which is in Mobile, Alabama. So those are both 2-site studies. So unfortunately, sort of not available in terms of participating as another site. But I will just briefly mention the project that Marie is talking about, where totally different project. We're conducting a national survey of cancer centers, all 1,326 of them, at least according to the COC website, to ascertain the state of caregiving services. Our long-term objective with this survey is to develop what I'm thinking of as a caregiving incubator, which would help to assist and coach cancer centers in adopting and implementing caregiving interventions. I know Virginia Sun's on the call. She's got stuff that needs to be implemented out there. And so I think that to help accelerate the translation from research to practice, that different project is trying to develop this incubator concept, which would act like an organization or an entity that would help coach and assist cancer centers with adopting and implementing these types of evidence-based programs.
Great. So we have to close, unfortunately, for now, but this isn't the last that you'll hear from Nick as we continue to engage him in helping us think about the caregiver trial trials that could be through the Palliative and End-of-Life Care Committee and SWOG. And Valerie, one of our advocates, had commented about the positive aspects of using lay navigators as an important untapped resource. So I'm going to turn it over to Mark, I think.
Yes, and it's my privilege to continue with the agenda. And we want to talk about developing concepts discussion, and 2016 is the concept for providing palliative care with nurse practitioners led by Vincent Chung and Virginia Sun. And I see Virginia, I'll turn it over to you. Please give us an update on where things stand.
Sure, thank you. Great to see everyone. I'm here on behalf of Vincent and myself to share an update on S2016, which is a randomized phase 3 trial of a primary palliative care intervention for quality of life in metastatic pancreatic cancer patients and family caregivers. I do want to acknowledge Marie Bakaitis as our committee co-chair, who has really been helping us with developing this concept. Catherine Guthrie for her expertise and suggestions and guidance in terms of statistical design, and also for the advocacy and patient perspective from Valerie, and also the family caregiver perspective from Carol. Thank you so much for all of your help. Next slide, please. So this is just a very quick background. Many of you know that palliative care represents an important aspect of care for pancreatic cancer patients. Symptom management and attention to quality of life is critical to this population. Palliative care is considered the gold standard of care for our patients with cancer now, but there is also a significant shortage of specialists that cannot meet the current or future demands. And there is a need for scalable approaches to meet the growing demand for palliative care for our patients and their families. And a comprehensive patient assessment administered centrally, or intervention administered centrally by generalist advanced practice nurses. So this is where the primary palliative care component comes in, that the notion is that everyone who is taking care of a cancer patient should have the basic principles and skill sets to deliver palliative care. And so this is our focus in terms of primary palliative care with generalist advanced practice nurses that can help with identifying needs early and can guide interventions. Next slide. This is our study schema, which we have shared previously as well. So this is a randomized trial design. We are interested in accruing here, as you can see in terms of the eligibility criteria, patients with metastatic pancreatic adenocarcinoma. We will aim to enroll them within 8 weeks of initial diagnosis of their cancer, an ECOG performance status of 0 to 2. We are going to be focusing on English and Spanish-speaking populations for this trial, age 18 years and older, which is the definition of adults, and the willingness to complete questionnaires, because most of our primary outcomes and pretty much all of our outcomes are going to be patient-reported and family caregiver-reported outcomes. And we will also be enrolling family caregivers. Patients will not be excluded from participation if they don't have a family caregiver identified, but we are going to really focus on the ability to try to enroll as many dyads as possible. Upon informed consent, the participants will complete baseline surveys. They will be randomized to one of two arms. The first arm is our intervention, which is a primary palliative care intervention plus standard oncology care. This will be centrally administered by our trained APRNs at City of Hope, so Vincent and I can have very good and easy ways to sort of monitor intervention fidelity as well. The intervention is a 12 telephone session intervention provided over a 3-month period, and these are broken up for 6 sessions for patients and 6 for family caregivers. And we will be focusing on quality of life content in each of these sessions. They will also receive a resource manual, and palliative care consultations, if available at the sites, are obviously can be requested by the patient as well as their oncology team. Our control condition is an intention control condition, which includes just overall quality of life education plus standard oncology care. This will be delivered over 12 telephone sessions as well, same dose as the intervention arm, but the focus here is really asking the participants if they have any questions related to the NCI Coping with Advanced Cancer booklet. And this group will also, if available, be able to have palliative care consultations upon request. We follow the participants at 3 months and at 6 months. Next slide. This is our final slide. So just a quick overview of the statistical plan. A randomization will be stratified by performance scores. And we are looking at enrolling a total of 170 evaluable participants at 85 per arm. And if we take into account 25% attrition, this will take us to about 238. I believe that's our newest number. And we are anticipating accrual completion to be about 4 years, assuming a minimum of 4 to 5 accruals per month across all sites, with at least 10 to 15 participating sites. Our status right now is we are working hard to gain funding to support this trial. We just submitted last week for our new R01 grant to the NCI, and hope to have that reviewed early next year and be able to gain some funding for support to conduct this trial within NCORP. Thank you very much. Happy to take any questions.
Well, thank you, Virginia. I'll just comment that we think this is a high priority for this committee, for SWOG and for the National Cancer Institute, and we are wanting to use every resource and every thought we can to help you get the funding.
Thank you. Persistence is key, so we'll keep trying and appreciate everyone's feedback and support.
So any comment from clinicians in the audience or people that see patients that what you think of the idea of a remote intervention to provide palliative care where it might not be available? Okay. Well, we'll move on to the next concept under development. Dr. Yara Solomon will.
I'll introduce.
Okay.
So, so this is a study that Yara is going to update us on, that both our advocates and other members of our committee have placed a high priority, and so it's an important study, but it's had some issues. So Yara, you're there to update everybody?
Yes, good morning, everyone. Thank you, Dr. Krause. So actually the title of our study has evolved since probably our last discussion or update. And it's now called a Limited Institution Feasibility Study to Estimate the Acceptance of Depression Screening in Participants Making the First Oral Request for Medical Aid in Dying. Next slide, please. So briefly, just as a reminder, the background for this study was the fact that the Medical Aid in Dying or Death with Dignity Act has now been made legal in 11 United States venues. And all of these laws do require patients to have decisional capacity to consent to MAID. In a few studies that looked at the prevalence of depression in patients requesting MAID, the rate is, estimated rate is about 25%. But the proactive screening for depression is inconsistent across centers that participate in MAID. In some of the studies where psychiatrists were asked to what extent depression could impact the patient's capacity to consent, more than half of them expressed concerns about that. Physicians who are involved in medical aid in dying may request a psychological or psychiatric evaluation for capacity assessment, but these referrals for any type of mental health evaluation actually rarely happen, despite high rates of depression in this patient population. Next, please. So this is our original study schema that describes the process of recruiting patients who are making their first oral request for medical aid in dying. As you may know, there are, for most of these laws, there are 2 requests separated by a certain period of time required for participation. The patients would be offered to fill out a self-screening instrument called PHQ-9, Patient Health Questionnaire, that is designed to screen for symptoms of depression. For those patients who would accept, fill out the screener, then depending on the score, if needed, and if they're accepting of that, they could be provided a referral for further mental health care. The patients who would qualify would have to be adults. Obviously, these laws in the United States only apply to adult patients. And then the plan will be to follow for study outcomes with the original pilot that is included, the patient proceeding or not proceeding with medical aid in dying. Next, please. So the most recent update following the NCI Steering Committee review of the study proposal that was rejected by them and we took all of their feedback into serious consideration. Some of the feedback comments I'm listing here had to do with the, kind of concerns about having compelling argument for actually knowing what the prevalence of depression is as related to MAID, or even being able to estimate that reliably based just on a pilot study and a relatively small number of patients. Also questioning whether there is really any point in screening for depression if we don't have sufficiently effective and fast-acting treatment to offer for depression. Several concerns related to the autonomous decision-making for patients and whether screening them for depression could potentially delay their access to medical aid in dying. And then again, the feasibility of recruitment of the desired sample size. So these are some of the comments that we discussed, and we decided that perhaps redefining the study as a feasibility study that would allow us to obtain preliminary data on patients' willingness to participate in screening for depression, and possibly including some qualitative measures as well, with an accrual goal of a smaller number of patients, 30 to 40, while at the same time exploring alternative venues of funding, for example, HOPE grant or SEED grant through the HOPE grant. So that's our update. And I'm sorry, our team is planning to meet this month to discuss further steps. So comments or questions?
Yeah, just a comment from me first, and this is like one of those many ideas that the time may not be quite right yet, meaning for people to put their sort of arms around this kind of study, which clearly is important. And so going back and getting some pilot data showing that we can do it is maybe the best way to then come back to the steering committee eventually. Does anyone, well, there's no questions on the chat that I see. Does anybody want to speak up or have any questions or thoughts?
Having been involved in this is Frank Maskins for a long time, and one of the authors of early MAID issues. I think this is a very reasonable decision. Further, I think it will be continuingly difficult to determine what comes first, the depression or the feeling of hopelessness. Although one would hope that maybe you can sort that out. I'm skeptical, but I think going the feasibility study is a very appropriate and timely response because more and more states are adopting these policies.
Great, thank you.
Thank you.
And I just want to echo for myself and that as co-chair that we are very much behind this protocol and this as a priority study for our committee to pursue, given the high focus on suffering and depression for people who are reaching the end of their illness.
Thank you.
Thank you, Marie. Thank you, Robert, and thank you, Dr. Salmon. The next developing concept, Dr. Subaya is on duty in the palliative care service at MD Anderson, and I don't think is available. She messaged me earlier. Shwar, are you on the call? But she is the PI for a study to improve provider communication, and that has been funded by the Hope Foundation last year. After getting things organized, it will be an intervention where providers go online to the CAPC website and take 5 of these 20-minute modules to improve their communication skills around these end-of-life issues. And there's a questionnaire beforehand and afterward, and a little financial incentive for them. It's not a SWOG study with a number, but it will be a study that will be used to prepare a subsequent SWOG study. And a new or an emphasis that I think our committee is going to be going forward in is the idea of improving the patient experience by improving provider communication skills, empathy, hope, and actually well-being. Any questions or comments about that before we switch over to completed studies with Dr. Kraus? Okay, Dr. Kraus, I'll turn it over to you.
Well, the next study is actually is Virginia Sun's active study, or one active study that is moving forward quite well. Virginia, do you want to?
Sure.
Okay.
Happy to give an update. Thank you again for the time. This is SWOG S1820, a randomized trial of the altering intake managing symptoms intervention for bowel dysfunction and rectal cancer survivors compared to a healthy living education control. This is a feasibility and preliminary efficacy study, and we fondly call our intervention AIMS-RC. We are grateful for the support from NCIR 21 as well as the Hope Foundation for Cancer Research Clinical Trial Support Funds. Next slide, please. I want to take this time to acknowledge our amazing team. It certainly takes, it's not just the study chair. Everybody's participation and support is very important for the success of a trial. I want to acknowledge our co-chairs, Dr. Cynthia Thompson at the University of Arizona, Dr. Tracy Crane. Actually, she is at the University of Miami now, and that will be changed. And of course, Dr. Krause's support as the committee co-chair. I'm very grateful for the biostatistical and data operations support from Dr. Catherine Guthrie, Katie Arnold, Roxanne Tapaccio, and everyone at the SWOG Statistics and Data Management Center. And I'm grateful for Christy Klepetko's leadership in terms of protocol development and coordination. And our nurse coordinator, Krista Braun-Inglis at the University of Hawaii, for her input from an NCORP perspective in terms of the success of the trial. Our patient research advocates, Lee Jones and Florence Cortilla. We have 2 GI committee champions, Dr. Mazen Al-Kaspouls from Surgical Oncology and Dr. Stacy Cohen from University of Washington and from a medical oncology perspective. And finally, our study coordinator and coaching team that is at the University of Arizona under the leadership of Dr. Thompson and Dr. Crane. And we very much appreciate their support and their coaching leadership for the trial. Next slide. This is the study schema, just a reminder of our S1820's design. We are focusing on rectal cancer survivors. Our target population is target sample size is 94, 47 per arm. We are enrolling survivors with rectal cancer between 6 to 24 months post-treatment completion. We are enrolling both ostomy or anastomosis participants. For the anastomosis participants, we will also be screening them at the consenting stage for lower anterior resection syndrome score of 21 to 42, which indicates a minor or moderate or major symptoms. We are focusing on English-speaking populations for this trial in 18 years and older, which is the adult population definition. Upon informed consent, they will complete baseline surveys, then enter into a period about 14 to 21 days of a run-in period. And this was a design that we had added to the overall trial to really give patients a flavor of what the trial participation is all about. And also scientifically, it does help with adherence as well. So during this run-in period time, by telephone, they will be completing 24-hour dietary recall, a 3-day food and symptom diary. And once they complete that process, they will be randomized to either the intervention arms, the AIMS-RC intervention arm, or an attention control arm, which we are focusing on healthy living education. So AIMS-RC is a 10 telephone coaching call intervention that's delivered over a 4-month period. Each of the sessions last about 20 to 40 minutes. Within each of these sessions, we coach participants on classic and behavior change approaches such as goal setting, identifying and overcoming challenges in terms of managing the bowel symptoms. We use a food and symptom diary to guide them in terms of identifying which foods are most troublesome for them in terms of bowel symptoms. And the coaches use that to guide appropriate education in terms of food preparation, as well as food diet modification. And the framework that we use in the coaching is the Motivational Interviewing and Problem Solving, or MAPS framework. Participants will receive the AIMS-RC resource manual, and also in between the telephone sessions receive personalized text or email messaging based on their preference. And these are personalized support for them between phone calls to help them with the diet modification. The attention control arm is also delivered across 4 months through 10 telephone calls, lasting about 20 to 40 minutes. In this arm, the focus is on 10 healthy living topics. So instead of the coaching in relation to diet modification, we are focusing on these 10 healthy living education topics for post-treatment survivorship. They will also receive a resource manual and also receive text and email messaging, but these will be more automated and standard in relation to the healthy living education topics. We then follow up our participants at week 18 and week 26, primarily with patient-reported outcomes. The coaching for both of these arms are all centrally administered by the trained health coaches at University of Arizona under Dr. Thompson and Dr. Crane's guidance and leadership. Our primary endpoint is bowel function score as measured by the Memorial Sloan Kettering Cancer Center Bowel Function Index at 18 weeks. We have several secondary outcomes, which includes the LAR score, self-efficacy, motivation, positive and negative affect. We are also going to be looking at diet quality using the 24-hour dietary recalls, which are collected at each of these time points, and also be looking at feasibility, adherence, retention, and acceptability. Next slide. So this is our accrual update, and we are very, very grateful. I want to thank everyone and all the sites that are participating. We were able to maintain accrual relatively steadily through the pandemic. And so we're very grateful for all the sites and all the site PI and sites coordinators support. We are now at 78% accrual completion. And we were activated on December 9th, 2019. Our current accrual as of yesterday is 74 out of 94 randomized to either one of the arms. I want to also say thank you to all our top accruing sites here, as you can see on this side of the slide, including UC Irvine, William Beaumont, and many others, MD Anderson, Seattle Cancer Care Alliance. Many thanks to your help with accrual. And we are now open officially at 202 sites. Many of these are, of course, NCORP sites and all of their affiliates. And we have one protocol paper that was recently published this year. My contact number is here if anyone has any questions. We are moving slowly and steadily towards accrual completion. But again, accrual has been really wonderful for us so far, and I appreciate everyone's support. Thank you so much.
So this is obviously an exciting slide for our committee, that this, even through COVID, this study has been able to continue to accrue and obviously will accrue to completion, which will be monumental, and we're looking forward to that. And it's a tribute to Virginia and the team she has assembled, the team that meets regularly and continually looks under every rock to ensure we're doing everything. I don't see any questions on the chat. Are there any questions anybody has? Okay. All right. Well, thanks, Virginia. So I'm going to give a very brief update. If you can bring that slide back up. On S1316, of course, our complete trial on malignant bowel obstruction. So we're still undergoing lots of things related to the primary analysis. Most of that has been completed. Katie Arnold's done a tremendous job, where there are some final cleaning and updating that's being done, including getting some final medication data inpatient that we had requested from the sites, and we're working on that. And then the final sort of analysis that will be part of the primary paper is the MD Anderson symptom inventory. And Katie and the team that we're working also with the team at the Mayo Clinic, who were originally, Jeff Sloan and his team are helping with that. And so hopefully that'll be done within the next month or so. And then we'll be looking to, the paper is in process. So the other thing we're doing is we developed a surgery report that is more in depth than originally we had written for, and that's taken a lot of effort from several people who are helping to complete the study chair reviews. And that is so that we can look a little more in depth at what kind of operations were needed and efficacy. And then, so there's lots of future things that were going to be in process. First of all, the diet, we have a lot of dietary data. For the primary paper, it's gonna be fairly basic, but working with Cindy Thompson and her group at Arizona, we're gonna do a more in-depth examination of that data. There's lots of requests or lots of potential to do subgroup analyses. There's a proposal working with the team, the healthcare team through the Stats Center, looking at some healthcare utilization and making estimates based on hospitalization, et cetera. And then we do, one of the other instruments that we utilized in the study was the EQ5D, so we can understand better preference-based quality of life from our participants and potentially look at qualities as well. So that's where we are. And I don't know if anyone has any questions. Okay. Then moving on, the next on the agenda. So Mark, I think that's you if you want to.
So thank you. We have new business, and this is a number of studies that we're developing. And I want to introduce our speakers, and they'll briefly tell the story of the projects that are in development. And some of these have to do with our group, Advanced Cancer Communication, Education, and Advanced Care Planning Training, so-called ACCEPT group, and we meet regularly. I want to introduce Dr. Feldman to talk about the HOPE workshop intervention that he and Dr. Korn are pioneering.
Great.
Dave?
Sure. Next slide, please. So I think I only have about 5 minutes, so I'll try to keep it short. I want to give you a brief update on the work that we've been doing on HOPE in our ACCEPT group. I want to update you. You've heard me talk about HOPE a variety of times in this meeting. So I want to let you know sort of what's happened since the last meeting about 6 months ago, and also talk about a concept in development. And this specifically concerns HOPE and HOPE enhancement interventions in both oncology professionals, so us, and patients. So next slide, please. So first of all, I just want to say that we have recently had, this is hot off the press, just now published online in the journal Cancer. And this is a secondary analysis of Marie Bakaitis's data sets ENABLE-2 and ENABLE-3. And I'm sure you're familiar with the ENABLE or early palliative care intervention. So these two data sets rolled together were 529 patients with advanced cancers. And the reason that it was a secondary analysis is we were able to find 3 items in the initial studies that directly asked about hope. And so we were able to sort of cobble those together and make a post hoc or ad hoc hope index. And you can see on the right, the survival curves. This is for low and high hope groups. And we were able to find that indeed hope did differentially predict prospectively survival. And so I'll let the curves speak for themselves for now, unless you have any other questions about that a little bit later. Next slide. So I think that really highlights the importance, the potential importance of hope in patients. We're also very interested in hope in oncology professionals, in providers. And so this slide actually summarizes a poster that was presented at the 2021 ASCO Quality Care Symposium just a few weeks ago, and you can see the co-authors there. And this concerns a brief single session hope intervention for oncology professionals. And the reason that we thought this was important is, you may recall about a year ago, I presented research from a survey of SWOG members, investigators, clinicians, showing a robust link between hope and burnout, which is, of course, something that all of us are concerned with right about now. And that's since been published in the Journal of Oncology Practice. And so we wanted to do a small scale feasibility and acceptability study in SWOG members, all oncology professionals. It's a very small scale study. It was 26, an N of 26, and you can see the breakdown of professions to the right. And this was a single 2-hour intervention session delivered via Zoom to 6 to 8 participants per group. And it was enhanced by an app that we call the Hoptimize app that was developed with assistance and know-how and funding from a nonprofit organization in Israel that is run by one of our co-authors, Ben Korn, and his wife, Devorah Korn. And measurement took place post-intervention only via a survey link emailed to participants. So this was a very straightforward, small-scale feasibility and acceptability study. It didn't have 2 arms. It didn't have pre-post assessments. It was simply a post-assessment measure. Go ahead and head to the next slide. So this is just one of the results. We actually had several measures, but I wanted to give you something to take a look at. These are ratings on the 4 elements of the Kirkpatrick's training evaluation model, which is probably the most common way of measuring outcomes of training opportunities, professional training opportunities in medicine and other professions. And these are all on scales of 1 to 8. So you can see the mean ratings are really quite high. So participants found that the workshop intervention was relevant and engaging. They learned something. They said it would change how they approached something or behaved in some way. And they said that they felt more hopeful as a result of the workshop. So go ahead to the next slide. So that's really in professionals, and we hope to expand that into a larger scale, hopefully 2-arm study looking more at efficacy rather than simply feasibility and acceptability. We also hope to expand this to breast cancer populations, so to patient populations. And I just want to give you a preview of a concept that is very much under development. So I'm not going to be able to give you many details, and that is applying this to women with breast cancer who are taking endocrine therapy. So I don't think I need to tell any of you that endocrine therapy adherence is relatively low for women living with breast cancer, for whom coping with pain and side effects and maintaining hope are often significant challenges. And the reason we think that hope is relevant here is that there is a good amount of past research showing that hope predicts adherence in other populations. So I've cited a couple of them here. For instance, Court et al. In 2012 found that hope was prospectively related to rehabilitation adherence and outcome in a heterogeneous sample of adults with spinal cord injury, stroke, amputation, and hip and knee replacement. And there's also research showing that hope is related to coping with pain and other symptoms For instance, Hope is Better is related to better coping with chronic pain in a variety of populations, including adults with spinal cord injury and adolescent burn survivors. And so we're currently working on, and I wish I could give you more details, working up a one-page proposal that would involve applying a similar intervention to the one that we provided to providers, but to patients with breast cancer undergoing endocrine therapy, and looking as our primary outcome at adherence, but also at pain and coping and a variety of other outcomes, well-being outcomes and quality of life outcomes in general. So I will stop there. Thank you for your attention.
Dr. Feldman, thank you very much. And I'll just offer any questions. I don't see anything in the chat, but speak up if you have some thoughts. Dr. Symington is asking about we talking about coping with pain, and this is directed at kind of everyone, and Dr. Feldman's issues of Hope dealing with coping with pain, and she's asking the broader question about the access to opioids and with all the regulatory issues around narcotics. And Dave, any comment on that in terms of
that's
how
above,
that affects?
that's to some degree above my pay grade. I'm really a psychologist who does a lot of research on hope. I'll answer it in terms of hope and pain coping. There's a variety of pieces of research that show that people who have naturally occurring higher levels of hope actually cope with pain less in chronic pain conditions, and actually report that the pain is lower. And these are prospective or longitudinal kinds of analyses. What we're lacking really are more causal analyses. What we're lacking is, can we raise hope using hope enhancement interventions and seeing if that has some kind of an impact on felt pain or perceived pain, but also pain coping and functioning, general functioning with regard to pain. I can't really answer the opioid question. I certainly throw that out for anyone else who can.
And Dr. Feldman, Dr. Rowland is asking, how is hope defined in this study?
It's a good question, and I'd probably need about an hour to tell you that. Suffice it to say, hope is not defined as hope for cure. That is a very specific instance of hope. And I think in medicine, we often tend to sort of equate hope and cure. This is a more general definition of hope that involves the general belief that it is possible to move towards a better future, and that is to achieve your goals sort of writ large. So we all have goals in our lives that are important to us, that we're moving towards. I think we're more hopeful when we believe that those goals are somewhat under our control, that we can do something to move towards achieving those goals or somehow realizing those goals. There are a variety of ways of measuring hope according to this model or operationalization. The most common one is known as the Adult Hope Scale, which is a 12-item measure of hope, which was developed in the 90s and has probably, 200 studies under its belt at this point, which has been shown to be a valid and reliable measure of hope and is related in a variety of populations to things like lower depression, lower anxiety, as I said, better pain coping, greater functionality in the midst of chronic illness, greater meaning in life, a variety of other outcomes as well.
Well, and Dave, after that eloquent explanation, I'll summarize. Dr. Rowland says we should put this in the intro to the slides, and a point well taken. But we can just write on your forehead goals, pathways, and agency. And
those are the three components. That's right.
Okay,
that's right.
So
and I always struggle with, do I introduce hope in the definition of hope each time, because it takes so much time to do. So in this context, I didn't, but thank you for the opportunity to define it.
Okay, so, and we're getting a number of comments about hope and fatigue, and about hope and pain management, and just to let people know, this is going to be an ongoing effort, and we're interested in ideas, and we're going to hear about that in a little bit. But people who want to participate in these sorts of studies and the ones that are going to be discussed in the next few minutes are welcome to get in touch with the committee. The next new business I want to talk about is an advanced care planning intervention. And we have been discussing this for a year or more. And the idea that's being developed, and Dr. Subaya is going to be the principal investigator, and she's tied up today, is to have a care coordinator or navigator introduce to the patient a questionnaire that determines how ready a person is to talk about advanced care planning. Specifically, are they ready to designate a durable healthcare power of attorney? And there's a range of answers to that, and that can be described as a person's readiness for advanced care planning. And then the intervention will be to offer a website called prepareforyourcare.org, and this has been developed by Dr. Rebecca Sidori, University of California, San Francisco, and it's an extremely well-developed website and program. And the basic concept is to assess readiness, offer the program, and then 3 months later check in and see if that readiness has changed, and also even to include the caregivers in that discussion. So this is a concept under development, and there will be more to that. And we've even talked about a specific request for people with an interest in advanced care planning, and some of the geriatricians and other people who are SWOG investigators. Please get in touch with us if you're interested.
Mark, we need to back up the slide because we're on the wrong slide here.
We haven't gotten down to Ready Band yet, but
okay.
Okay.
Sorry.
So we're so I don't have a slide for the prepare advanced care planning.
Okay. And I'm sorry to interrupt here because there's going to be a conflict with the nursing committee starting at noon.
Okay.
I would like to request that we reorganize and have the APP proposal for HOPE funding go next if possible. And we need to have Krista Braun-Inglis added as a panelist. This will just take a few minutes, and I wanted to have Dr. Jamie Myers give a little update on what that is about so that she can then get over to get her meeting started, get the nursing committee meeting started.
Okay, so Marie, now's the time. Let's just go directly to that right now.
Great. Thank you so much, Marie and Mark, for just a couple minutes to highlight a very exciting proposal that we're doing in conjunction between the Nursing Research Subcommittee and the Palliative Care and End of Life Committee. We sent in a joint application for HOPE funding in response to updated policies related to nurse scientist role within SWOG and advanced practice providers roles within SWOG. We really want to leverage that power and involvement in SWOG clinical trials research. So the committee, and under Krista Braun-Inglis's leadership, who you'll hear from in a moment, did submit a three-pronged multi-year initiative proposal to the HOPE Foundation for review. And year one will involve a 2-hour educational symposium focused on advanced practice providers' roles within clinical trials research that we believe will help us recruit and build the stable, if you will, of leveraging the power of these practitioners. Year two then will be the development of an advanced practice provider task force that can talk about some of the barriers that we have to full participation within clinical trials research networks and propose some effective strategies to mitigate those barriers. And years 3 to 5, the vision would be that we develop some CME focused best practices that can be enduring materials that and can be accessed by people as they're new to the clinical trials research network. So with that, I'll turn over to Krista to see if she has anything that she'd like to add.
Oh, Brooke added Krista, right, Krista?
I see her there, but I don't hear her yet.
Yeah, her rectangle lit up, but we didn't hear her.
Can you hear me?
There you are.
Yes, now. Yeah.
Can you hear me? You can hear
Yes.
me?
Yes.
Oh, okay. Jamie, I think you covered it really well. And I do think that the Hope Foundation is currently reviewing it. So we should hear something soon. So that's very exciting. Welcome to take any questions from the audience.
And while people are thinking about questions, just a little celebratory note. This is now Dr. Krista Braun-English. She finished her DNP very recently, so kudos to her.
Oh, congratulations.
Good job.
Thank you. Thank you.
Great.
But I do think this proposal can definitely work towards bringing more APPs into SWOG and the research-based network overall, because I think we're doing so much now of the clinical work, and we can have really, truly meaningful roles, especially in groups like end-of-life, palliative care, supportive care, you know, many different aspects. So thank you. And thanks to the Palliative Care and End-of-Life Committee for being part of this.
You bet. Thanks, Mark, for letting us reorganize.
Sure.
Okay. Jump off.
So going back to new business, we talked about the advanced care planning, and then we're also developing an empathy concept that is still kind of being rethought. Dr. Accrual and Heidi Deininger, Dr. Heidi Deininger, are working on this, and they it is a question of reviewing this particular intervention on training providers in empathy to see whether it's an intervention worthy of study in our network. Dr. Deininger or Dr. Accrual, do you care to make a comment? So I think I didn't see Rajiv, and that idea is in development, but more to follow on that. And the last of the new business we can go back to the slides now, to the slide that was up before. I'll introduce Dr. Lauren Fowler, and she is a PhD in neurosciences at the University of South Carolina School of Medicine in Greenville. It's the medical school adjacent to the Prisma Health Center in Greenville, South Carolina. And I have collaborated with her in the last year or so with this idea of fatigue, sleep, and cancer-related cognitive impairment. And she has a concept in development that she'll share just a little bit with. Go ahead.
Hi, everyone. I have worked with Dr. O'Rourke and several people on this call to help develop a study where we're interested in looking at the impact of fatigue, sleep on cancer-related cognitive impairment, as well as pain perception. And we're using a novel device that allows us to do objective longitudinal assessment of sleep in breast cancer survivors. And if you see on the screen, the Ready Band, it's just a little watch that someone wears. And it's a typical actigraph that is very valid and has been validated with polysomnography. And it's non-invasive and easy to wear. But the great thing about it is the app that goes with it and the proprietary algorithm that the manufacturers have that allows you to use the sleep data and to compile it longitudinally so that you can look at not only the effects of sleep deprivation and fragmented sleep short term, as well as looking at it long term. So what we're proposing is to use this across a series of 3 months with patients, and they get to interact with their fatigue data in real time, which is really nice. And we've used this protocol with other groups. And what we found is that when they use the app and they actually can track their own fatigue data, they feel empowered to make changes and also to realize that maybe changes in their perceptions of things like fatigue and cognitive impairment are really due to that sleep deprivation and not to some other personal failing. And so we've used this primarily in shift work. This has been used extensively in different industries, but we're excited to use this in breast cancer survivors. It also makes predictions about cognitive impairment. And we are hoping to use different questionnaires to also assess cognitive ability, as well as communication with the provider and whether or not the patient feels heard and understood, as well as pain perception. So we're really excited about this, and I look forward to any feedback that or suggestions that anyone has.
I'll open it up for questions or comments.
This is a great concept. Could you just explain on the schema there where it says no access to app, no access for previous month, and then end of month? Could you just say a little bit more about that?
Of course. And so one of the things that we have found in previous research is that at least in people who are working shift work, their ability to access the app and to look at their own data makes a difference in their perceptions of their own fatigue. And they feel more empowered when they do have access to the app. We're not sure if that actually would happen in patients. I haven't worked in a patient sample yet. So what we would do is we would have them wear the Ready Band, and we can see their fatigue and we can see their scores as researchers, but they don't have access to it that first month. And then after that, they have real-time access, and they'll be able to go back and see their scores. And what's amazing about this device is it not only tells you where you are now, but it helps you predict your best time of day for cognitive processing. So what we have found in physicians is they really enjoy this because they're like, if I'm planning something out and I actually have control, this is the time I want to do it.
That's great. Thanks. And Dawn commented in the chat that the survivorship committee is focusing on sleep this meeting. And so it might be worth attending that if you're able, Dr. Fowler.
Thank you.
They're going to have a speaker on sleep, and I think it's a rich field going forward.
Excellent.
And Dr. Symington commented about hope, fatigue, and positivity, and about the burden of positivity. People think if I just had a more positive attitude, I would have done better. And I think it really taps into the whole patient experience and what we're trying to get at with this end of life and palliative care. It's the experience is multifaceted, and it's more than just a PROMIS 29 score or a pain scale score. So well said. And that finishes the new business, and we are ready for closing remarks, and we're on time. Dr. Bakaitis, Dr. Kraus, any comments?
Well, I guess a quick thank you to everybody for participating, all of our speakers and everyone who participated. And just to reiterate, first of all, we have our monthly meetings. Hopefully you get those announcements. And we're always looking for new ideas. And so if you or your colleagues have new ideas, we each have our own expertise, and we can hopefully shepherd ideas up the ladder and initiate more studies for our committee. The other thing I just want to say briefly, one of the things we talked about at NCORE last night is, if anyone's aware of other studies in other groups that are really relevant to this population that we should be supporting, we want to do that too. And so please bring those forward. We're going to make an effort to try and be inclusive and discuss those with our meetings as well. But we'll rely on our team here to help us identify studies that we should be participating with and promoting.
Thanks, Mark. I don't have any other comments except to say that I will love to get feedback from people and volunteers for our next meeting, which in the spring, which will be in April, for speakers and ideas for the next meeting, as well as volunteers. I like to see if when we're in person, if we can continue having our wellness check-ins, even though we will hopefully be in person and be able to do that. So appreciate the feedback from our members here about some ideas as we think about next meeting. And of course, we have our monthly meetings that we can begin to plan on it. But while I have a larger captive audience, I wanted to be sure that I'm got the message through that It's never too soon to start planning for the next meeting and the format and how we can, hopefully we'll be together, continue the vibrant work that we've been doing here at this current meeting.
Good deal. Thank you very much. We'll let you go with some extra time then. Take care.
Thanks.